Hi,
Hello.
here is Snježana and Mia again.
Yes. Last time in our last episode, we talked about the differences in the harvesting techniques, structure, and indications for de-epithelialized and subepithelial connective tissue graft. Can you remind us a little bit about it?
Yes, for everyone who missed this episode, it is still available, of course. But let me give a summary. We talked about one of our favorite topics that we are very passionate about it, difference about subepithelial and de-epithelialized connective tissue graft. The difference is in harvesting technique. It means that de-epithelialized connective tissue graft is harvested more superficially than the subepithelial connective tissue graft. And it is not only harvesting technique. In the moment, we have a connective tissue that is harvested more deeply than de-epithelialized. There is also difference in histology, and these differences in histology explain differences in clinical behavior. And this is what we talked about last time.
And today, we will talk about how to use those grafts.
Yes.
So there are techniques for soft tissue augmentation around natural teeth, implants, and for the pontic sites.
And there are many techniques and many novel approaches and techniques for recession coverage. We have a coronally advanced flap technique with or without vertical incisions, and we do have tunneling techniques.
Back in the time when I was working with you, I remember that you were teaching me tunneling techniques. Why do you prefer it?
I do prefer tunneling techniques, and it is because of the clinical results that I see. It is, I started with recession coverage many years ago, and on the very beginning, it was a coronally advanced flap. And back at that time, I haven't done a periosteum releasing incision to advance my flap coronally, but undermined periosteum very far apically above the mucogingival junction, on the laterally, on the mesially, and de-attached periosteum because it gives a nice flap mobilization. Afterward, with the periosteum releasing incision, but one develops, and then I tried new techniques like double papilla technique, a laterally repositioned flap. It was really exciting to learn this, and then finally the tunneling techniques. And maybe tunneling technique, once one can do it, it was a little bit of the showing the muscles, and I can do it, so I repeat it, and I have done more and more often tunneling technique. And then when I've seen results, I really became addicted to the tunneling techniques. I've also done a Sulcular sanctis technique, but what I've seen, it is grooves in the gingiva, in attached gingiva. We don't talk about the scars, we talk about the grooves, but whatever we name it, it doesn't look very aesthetic. And I've seen grooves for up to 6 months after the recession coverage.
The Sulcular sanctis technique, it is a coronal advanced flap without the vertical incisions.
Exactly.
And the starting point for the measurements for the recession coverage is the highest recession, let's say the deepest recession. It's usually on the canines.
Yes.
And towards that recession, we incline our incisions in like a zigzag manner. Isn't it?
Exactly,
yeah.
Exactly. And it is maybe it is because of me, because it doesn't work that good in my hands, but even when I adapt very, very nicely in this splitted papilla tissue, these incisions, I see, and I have heard also from many other clinicians that they've seen up to 6 months, sometimes even longer, some growths.
So the morbidity is high, you would say?
No, actually not morbidity.
Mm-hmm.
Morbidity, the literature says that there is more morbidity with tunneling techniques. Yes, it is more swelling and even a little bit more pain. But then, you know, I think in more than 90% of our cases, what is the reason to cover the recession? Why do patients ask us to cover aesthetic? It's because of aesthetics. And these patients, they want to have instant aesthetic result. They, you know, they even 2 weeks after the recession coverage, it should look nicely. It should look nicely. The tunneling technique causes more swelling, and it is, I would say, it is because we prepare first our flap sharp with the blade coming from the sulcus, but then, especially in the area of the mucogingival junction, especially if there are some scars from previously apicoectomy, then we need to go to the semi-sharp instruments, tunneling knives. And when you use a tunneling knife, you feel, you simply feel
the releasing of the tissue.
Yes, the releasing of the tissue, and you feel some fibers, how you are pushing them until you actually destroy them, break them. You don't make a nice clean cut. And this is the reason for the swelling, for more swelling.
And which one would you say it's a time saving?
Oh, Sulcular technique, coronally advanced recession, coronally advanced buccal flap is it's easier to perform, and it is really good to start with it. It is easier to perform and it takes little time. This is what I do, you know, in very complex cases when I'm doing, placing some implants or doing some bone augmentations, then I have to cover recessions, and the surgery time is already long, then I go back to this technique, but very, very seldom.
And that technique requires even less CTG.
Yes, it is like Sulcular and Sanctis published, it requires less CTG. Why? It is when we are doing a tunnel, then we introduce our connective tissue graft all the way through the tunnel, from the first tooth to be covered to the last tooth that the recession should be covered. And Sulcular Sanctis, they say we can take smaller pieces of connective tissue graft or cut our graft into smaller pieces and apply connective tissue graft only in the size with less keratinized gingiva or with very thin mucosa, overlying mucosa. And this is, but the catch may be vascularity. Yes, especially, you know, you are a beginner in recession coverage and you are a beginner in connective tissue harvesting, and so you have small pieces to cover the root. And if connective tissue graft is placed solely on this exposed root surface, it doesn't have any blood supply from the base. And it can be catchy because it can undergo the necrosis. So it is, when we talked last time about the subepithelial and de-epithelialized connective tissue graft, I already thought that I faced twice a patient where I wasn't able to harvest sufficiently subepithelial connective tissue. And I think here, what is good is recommendation from, I'm sorry if I don't pronounce the name correctly, Zabalegui. It's not very, I really don't know how to pronounce it. But anyway, Zabalegui, he recommended to first check the donor site, to harvest the connective tissue graft, and then depending on the amount of connective tissue graft,
technique.
Yes, to choose the technique.
So you said that sometimes we do have small pieces of connective tissue graft, maybe our problem, maybe the problem of the patient. How do we try to not leave a lot of exposed CTG graft during the recession coverage?
If you have a long piece of connective tissue graft, and of course the patient is not a smoker and doesn't have any other background diseases that can make more difficult his healing. I haven't said it very nice, but you are not here because of my English language. If we have a long part of connective tissue graft that is on a well-vascularized base, then we can leave, of course, some parts of this connective tissue graft exposed, and it is going to be to epithelialize with the keratinized epithelium. But if we have a small pieces of connective tissue graft placed directly on the nuded root surface, then I wouldn't recommend to leave any part of it exposed. Yes.
Cover it whole with advanced.
Yes, yes. And it is also what I don't like about the coronally advanced flap is that the mucogingival junction is displaced, and you know,
the flat vestibulum.
Yes, flat vestibulum afterward. And if the aesthetic really matters already 2 weeks after the surgery, and often it does, then I would really go for the tunnel technique. Although it can be difficult if there is a with keratinized gingiva, with zone of keratinized gingiva.
Yes, 70% of the patients have width of keratinized gingiva somewhere in between 4 and 8 millimeters, 25% less than 4 millimeters, and 5% more than 8 millimeters.
Yes, more than 8 millimeters is really challenging.
Yes.
Why is it challenging?
Because it's really hard to tunnel it from the sulcular area.
Yes, it's really hard to tunnel it from the sulcular area. For this reason, we do have and utilize microblades, at least 15C blade. I mean, for the low jaw incisors, it must be a microblade. And the chance, the risk to cut the sulcus, to destroy the sulcus is less. But if the keratinized gingiva is really 7, 8, 9 millimeter, it's really, really hard to dissect it coming solely from the sulcus.
Yeah, and you can perforate.
Yes, you can perforate.
Even,
yes.
Because of the lack of the patients, maybe. Yes, and the huge advantage of the tunneling technique is papilla preservation.
Yes,
because the integrity is saved.
Yes. Blood supply is saved. We talked about the grooves, about the aesthetic, but it's really not only for this reason. It is the papilla integrity gives a better blood supply, of course,
and less mobility of the graft.
Yes. I even had a case. It was a colleague I've done tunnel technique for recession coverage. I have the case documented with all pus, with all suppuration that she had. Yes, colleague, of course.
Colleague, okay.
I remember very good. It was during the time of Eastern holiday. And I was left alone in the office. My partner has done vacation, and I was alone in the office. And I had to drive to the office twice daily for this colleague and to do, you know, some just saline with the saline washing the tissue. But interesting, connective tissue graft survived and recession were covered afterward. Very well documented case. Yes, I have to show you. Yes. Lucky, both of us.
Yes. So, we said for the tunnel technique that the integrity of papilla is saved. And how do we raise the flap? It's a supraperiostal. It's a splitting technique.
Yes.
Partial splitting technique.
Partial thickness flap. It is when we talk about a tunnel technique, then we automatically think on the partial thickness flap. The Retzke introduced the envelope technique, and then the Allen developed it, and he published the supraperiostal envelope for the multiple recession coverage, and then finally again Zabalugay, yes, he connected this tunnel, supraperiostal tunnel, and performed but papilla partial thickness flap. But nowadays, the tunnel is prepared mostly partial thickness flap, but in the area of the tunnels, this is published by Herzel, Allen, it is always a full thickness flap, and only the buccal part of the papilla is mobilized, only the buccal part of the papilla. Also, and this is again one of my favorite topics, it is when we are tunneling, and I have done also a lot of live surgeries for the students of university or for the colleagues doing my tunnel and showing them how I prepare partial thickness flap coming from the sulcus. But then, if I'm honest, I often felt the bone underneath my blade. Especially if the yuga is more pronounced, especially if the patient phenotype is thinner. And I mean, the average labial gingiva thickness is 0.5 millimeter. Of course, you come to the bone sometime. One very interesting study talking about immediately post-extraction placed implants. They have done volumetric measurements utilizing intraoral scanner and compared also CBCTs from the patients after implant placement and then after 1 year. What they have found that this soft tissue, connective tissue, stayed stable, and there was more bone resorption. More bone resorption was responsible for the reduction of the horizontal ridge volume, not soft tissue. Yes, and the explanation may be, and this is what also the authors pointed, is when we place post-extraction and implants, yuga is here, and this labial soft tissue is thin, and often we actually deattach periosteum from the bone, and this is the trigger for the bone resorption. And so also the Allen pointed in his work that partial thickness flap is performed where it is possible, but when the tissue is very thin, we go subperiosteally. And also Skulan, he modified the tunnel technique doing a partially thickness flap in the area of the recession above the mucogingival junction, but laterally to the recession, he goes subperiosteally.
But for me, the scariest part is to introduce that long graft into the tunnel.
Yes, through the sulcus.
Through the sulcus.
Yes, yes. It can be, both of us, we have seen also a live surgery video from a very famous clinician doing tunnel technique for the lower jaw incisor, and in the moment he introduced the connective tissue graft.
The papillas detached.
Papillas detached, and there was the tearing of the mucosa. Yes. It may be a risk, so one should always choose the tooth with the biggest sulcus to be able to introduce connective tissue graft. One have to handle the tissue very gentle. It's always good to combine tension with the sutures, like in the lasso technique, and the very gentle pushing, utilizing the tweezers. It is what helps. But sometimes, this is what I have done spontaneously many years ago. I added a small vertical incision in the more distal area to introduce connective tissue graft. And I have seen also recently, but it was published many years ago, that Allen introduced like a small vertical incision for the low jaw incisor tunneling technique to introduce a connective tissue graft.
To minimize complications.
To minimize the complications, yes.
And that approach is called VISTA.
No, this approach, sorry, Mia. Sorry. What Allen has done, okay, the tunnel is prepared coming from the sulcus, but he introduced just a vertical releasing incision coming from the sulcus into the vestibulum to introduce a connective tissue graft. VISTA incision, a vertical incision in vestibulum, is not utilized only to introduce connective tissue graft. It is utilized to prepare the tunnel. I know that you know about VISTA technique.
Yes. It is when we really have the width of the keratinized gingiva is really high.
Yes, when we had the width zone of keratinized gingiva. And we still do want to do some tunnel technique. We don't want to cut through the papillas on the tip of the papillas or on the base of papillas. We want to do a tunnel technique to have a great blood supply. But when the keratinized gingiva, the zone of the keratinized gingiva is really very width, then VISTA technique can be very helpful. Mia, you are always for definition. What does VISTA mean?
It is a vestibular incision, subperiosteal tunnel approach.
Yes. And it is basically?
It is basically a vertical incision through the whole width.
Full thickness flap, all the way to the bone. And then
you elevate.
We undermine underneath subperiosteally.
Yes.
And this way we get great flap mobility. This is what I mentioned. This is how I started with recession coverage. It was a coronally advanced flap, but without periosteum releasing incision, but we undermined a periosteum all the way above the mucogingival junction and laterally, mesially. So we got a nice flap mobility. And this is what is done in VISTA technique, but not elevating the flap and doing periosteum undermining, but coming from a vertical incision.
And with the VISTA, we can minimize the trauma.
Yes.
Like perforation of the keratinized tissue.
And of the sulcus, tearing of the sulcus.
Yes. We can use it for bone grafting.
This
Yes.
is like smart technique. Yes, actually VISTA
Yes.
approach. And what also Homa Zadeh published, who actually we have forgotten to mention Homa Zadeh. He was the first one who published VISTA technique for recession coverage, but also then for the surgical orthodontic treatment also. And very soon we are going to do a podcast. We submitted a nice paper about the VISTA technique for periodontal defects treatment. Stay tuned.
Are there any more indications for VISTA? We said for the shallow sulcus and for the
Yes.
Great amount of keratinized
gingiva. It makes it simpler and less risk. Yeah, I utilize VISTA technique actually to improve a peri-implant tissue. It is very, very often that when patients come for the follow-up, then the amount of the soft tissue buccally on the implant is not sufficient, mostly also the amount of the bone on the buccally, but we cannot improve it anymore, but we can improve the amount of the soft tissue. And here I don't go through the sulcus of the implant. I always apply VISTA technique, and it is really very, very handy and nice way to improve the peri-implant soft tissue. I often combine approach from the sulcus and from the vertical incision in order to mobilize the flap.
So when I imagine myself doing VISTA and tunneling technique, we said I would do VISTA subperiosteally. I have only bone. I would have only bone underneath the graft. And when I'm doing tunneling technique, then it is like 2 layers. I have a blood supply from above, from periosteum below. So I feel that I can leave more of the graft exposed.
It's good thinking. It's really good thinking. And when I started with the subperiosteal, with VISTA technique, with subperiosteal flap preparation, I actually have not expected to have equally nice and predictable results like with tunnel technique and partial flap preparation. But strangely, they don't differ. I haven't done a prospective study, but I would say I see the same amount of recession coverage when I utilize a VISTA technique, when I prepare the tunnel subperiosteal and connective tissue graft has less blood supply than with the partial thickness flap and the tunnel technique. I don't see differences. Not very often I leave parts of connective tissue exposed. It is maybe because a lot of my patients are unfortunately smokers, not heavy smokers. For heavy smokers, I don't do recession coverage, but some of them are smokers. I'm not aware of any research, of any study comparing survival rate of exposed connective tissue parts depending of if the recipient bed is prepared subperiosteally or partial thickness flap. But it is really, really good thinking. What I do see is the difference. Again, our favorite topic between de-epithelialized and subepithelial connective tissue graft, because de-epithelialized connective tissue grafts, they have less blood vessels than subepithelial connective tissue grafts, and they are very dense, and it takes longer for them to connect with the blood vessel from the recipient area. So when the parts of the epithelialized connective tissue grafts are left exposed, they tend to undergo necrosis more often. Mia, we started to talk again about
never-ending theme for us.
Never-ending.
We promise it's enough.
It's enough. If you want to know more about the epithelialized and subepithelial, please listen to our podcast to this topic. And now we say goodbye, and let's see what is going to be a topic
for the next episode.
Yes.
Yes.
Bye.
Bye.